Chairman Schuler and members of the committee, I am Julie Weidemann, Director of Palmer Home Medical in West Union, Iowa. I'm pleased to come before this subcommittee to discuss with you the profound risk of the DME POS competitive bidding program being implemented by the U.S. Department of Health and Human Services. I've worked in the HME industry since 1988. I started my home care career as a respiratory therapist, and in 1994 created and instituted Palmer Home Medical Supply, a department of Palmer Lutheran Health Center, which is a 25-bed hospital in West Union. We have 3 locations. I employ 10 people. We serve 10 counties in rural northeast Iowa, covering 2,500 square miles, and close to 50% of my client base are Medicare clients. I have the largest concern over the competitive bidding program due to the MMA 2003 provision that allows CMS to take the purported savings that is achieved in desperation bids from round 1 and apply pricing nationwide with a new fee schedule. Earlier, Representative Braley asked the question how competitive bidding is going to affect rural providers. And what was stated was that it was only going to affect metropolitan areas, and it really wasn't good. Rural providers were exempt. That is not true. What CMS can do is they can take the data from this round 1 and 2 bidding, and they can impose an inherent reasonableness standard on the entire industry, which will mean that rural providers will have a 26% cut in reimbursement. So no, I'm not in a competitive bidding area, but I'm still going to see the 26% cut that they're seeing in the metropolitan areas. If I have to take that 26% reduction, I will have no choice but to decrease the level of service I'm currently providing. And with the price of fuel, I may need to decrease the territory I provide service to. What then will happen to the patients out there in those outlying areas? What provider will be able to afford to help them? And if I'm decreasing my territory, that means I will most likely need to cut staff. My other major concern is that competitive bidding will simply limit choice for beneficiaries and will dramatically reduce the service they've always received and need to receive. Can a company 3 hours away that gets the bid provide quality service compared to what I can provide when I'm right down the street? My patients are going to suffer greatly from this program. Small business is going to suffer greatly as well, and will not be able to survive a 26% cut. And what happens to medical innovation? It will cease to exist in a low bid environment. Better technologies are expensive. And with the huge national bureaucracy that is being created at CMS, an increase of approximately 1,600 employees, what kind of savings will really be achieved at the expense of patients and small business? Also, there has been a lot of talk this morning about discussion on quality standards and accreditation. To this date, the HME provider quality standards are still in draft form. There's been no final release yet, so we don't know exactly what our standards are going to be. The new rent-to-purchase payment policy for home oxygen equipment enacted in the DRA requires that after a 36-month rental period, title and responsibility for maintenance and service for all home oxygen stationary and portable technologies would be transferred to the Medicare beneficiary. Just last week, one of my respiratory therapists was in a Salvation Army store in Cedar Rapids, Iowa, and sitting there was an oxygen concentrator and 3 oxygen tanks for sale for $50. No doctor order required. Oxygen is a drug that must be prescribed by a physician, and when beneficiaries start owning this equipment, where will it go when they no longer need it? Obviously, a Salvation Army, maybe a local garage sale, on eBay, the internet. As a respiratory therapist, this worries me to no end. Oxygen, when used inappropriately and without proper training, has very dangerous consequences that could result in death from underdosing or overdosing, or deadly fire due to lack of training in the safe use and storage of the oxygen. Providers currently educate each patient and their caregivers on these very critical issues. The cost for providers that is not in the equipment being provided. It is in the service. Patients don't call us for equipment. They call us for advice. We currently provide 24-hour emergency on-call service. We assist our patients with troubleshooting and proper use, equipment failures. We provide clinical assessments by respiratory therapists and nurses. Who's going to do all of this when the patients own their equipment? I cannot provide these services for free, and not many of my fixed-income Medicare patients can afford to pay me extra out of their Social Security check for these services. So it will simply not get done, and patients will be hospitalized more often. In 2002, there were 673,000 hospitalizations for people with chronic lung disease. Their average length of stay was 5.2 days, making the average cost of that hospital stay $18,000. In contrast, the current average annual cost for home oxygen therapy is $2,784, less than the average cost for one day in the hospital. I can provide this service for a whole year. Home care is the solution. It is not the problem with our medical industry and the Medicare expenditures that go out. What does this mean to me, rural Hopetown HME providers, and all our providers in a competitive bid area throughout America? I live in an area of the country with a large elderly population, and with almost 50% of my clients on Medicare, I truly fear what will happen to my customers and my small business when the competitive bidding storm thunders its way into rural America. I cannot survive if I cannot serve Medicare beneficiaries, nor can I survive providing our current quality of product and level of service with a 26% cut in payment. Due to this competitive bidding storm, small business will be destroyed and beneficiaries will be left to fend for themselves, threatening their current access to care and their quality of life. I call on Congress to immediately delay the implementation of this competitive bidding program, and as with any action that is taken to avert the train wreck that is competitive bidding, I ask that Congress include a repeal of the imposition of the 36-month cap on oxygen. As a provider, I support the implementation of a rational alternative process to determine Medicare pricing for DME items and services. I thank you for this opportunity. It's been quite an honor.